Good evening, everyone. I welcome you all on behalf of Cipla for the Advisory Board on nebulized long-acting bronchodilators in COPD. And I apologize for starting the meet quite late. Uh, for today's meet, we have Dr. Onithan with us. Dr. Onithan doesn't require any introduction, but as a formality, I'll go through Dr. Onithan's introduction. So, sir has done his MBBS from Orissa, his MD from SCB Medical College, Orissa, and his DIH from Annamalai University way back in 1996. Currently, Dr. Onithan is working with Hindustan Hospitals, and previously he has worked as registrar with prestigious Nanavati Hospital, Mumbai. He also has worked as a chest physician with Ministry of Health, Libya. He has worked as chest physician in couple of hospitals like Nair Hospital, Kerala, also in Kowai Medical Center and Hospital, Coimbatore, a couple of more hospitals in Coimbatore. Uh, Hello. Yeah, sir has also worked as a director at Kowai Respiratory Care and Research Center in Tamil Nadu, Coimbatore. Uh, so I welcome Dr. for facing the occasion as a moderator for this particular advisory board. Going through the panelists, we have with us. Hello. Yeah. Okay, I'll go ahead. So going through the we have with us Dr. Dr. Vivekananda, Dr. Velkumar, Dr. Prabhakaran, Dr. Gopinath, Dr. Hari Krishnan, Dr. Bharti Babu, Dr. Ilam Paruthi, Dr. Premanathan, Dr. Rajesh Kumar, Dr. Brighton, Dr. Anand Rajendran, Dr. Saravana Vasan, Dr. Anand Raja. So I welcome all the panelists for this particular advisory board, and I apologize if I have pronounced any of the names wrong. So with this short introduction, I request Sir to begin with the session. And I urge all the doctors to give your insights so that we are enriched with your valuable experience. Thank you.
This works. Thank you, Dr. Varsha, and good evening, all my friends and colleagues. First, outset, I would like to make a disclaimer that I am not a great guy to know more about COPD than you. Many of you must be knowing more than me many times on many aspects. So if there is anything, let us make it an interactive session. And I thank Cipla, Dr. Varsha and others of Cipla for inviting me to moderate this session. Now, coming to this, let us make it the COPD is a very common condition that is which makes the jinx of we have come off from the era when everything was branded as asthma. We have now distinct entities called asthma and COPD, but still many times we get confused which is asthma and which is COPD. So it is your clinical acumen, and plus the guidelines have helped over a period of time. The gold guidelines have really helped us to make things clear so that we have a distinct disease right now. Now I would put this question to all of you. At what stage of the majority of your patients consult you for the first time? Can I know if Palniyappan sir, please?
Moderate, sir.
Mostly moderate. Any other? Most of us, I think during our practice we see more of moderate, severe and very severe cases. We hardly see any mild cases. So the thing is, if we can pick them up during the mild phases, it will be much better and the management can be uh, served. Now, what is your initial pharmacological treatment for COPD in majority of the patients? Can I have an answer from?
Exactly, we do go with the dual bronchial therapy, most probably LABA, LAMA.
Yeah, right. That is what the guidelines say, and presently the stress is on LAMA and LABA and not much to be given ICS. But the thing is, most of the times what happens is, since we see very severe and very severe patients, we are confused whether not to give an ICS or not. So most of the time we'll end up initially giving ICS and later we come down and trim it down to ICS. There are two aspects to it. In my opinion, that is, what happens is the guidelines say escalate the therapy, but in our practice, de-escalation is much more a practical approach. Come down. That is a much better. But the thing is, there has been a lot of literature on ICS causing pneumonias and all those things. So initially, if you get a pure asthma, initially, I mean pure COPD, which is of a low grade, then only LAMA, then you step on to LABA, LAMA, or ICS LABA, or if you start with exacerbation, ICS LABA, LAMA, and then you slowly come, if they improve and over a period of time, you keep the ICS as low as possible and come down. Now, there, beg your pardon?
Incidence of pneumonia, I am not very much convinced with that. I don't see that much of pneumonia in
It's not pneumonia. What is happening is most of the infections which causing a little bit of infiltrates, that is called pneumonia. That is what is. It's more of respiratory infections. I have had patients who have been on steroids and were getting recurrent infections. This happens to two conditions, also with bronchiectasis. Many of them get a lot of infections when they are on inhaled corticosteroids, and as over a period of time, when you bring down the ICS, automatically many of them do not have less exacerbations. So the gold guidelines recently, what it 24 insists on is to bring down the exacerbations. That is what is one of the main ideas, not only to improve the patient's symptomatology, to reduce the exacerbations, that is important. So currently, in which are the settings in which you use nebulization? Obviously, all of the ICU we use, emergency wards when there is an exacerbation where we use, and home nebulization has come to stay. Many of the patients who are on home nebulization. Now coming to clinical scenarios where nebulizer therapy is preferred in patients with COPD. One of them is, of course, all of you know, we all practice that. When the patients have cognitive impairment, that means when the patient is not able to understand what the patient has to, it is very difficult to teach the patient. Mental retardation, there is a use of patient has got a lot of other problems. In that case, we tell them to go on nebulizers. Second is when the patient has got the problem with using an inhaler, like they have arthritis, Parkinsonism, stroke. Many patients you will come across who will come and they will have impairment because they cannot press the MDI. MDI, pressure on the MDI causes problems for them. The fingers do not work. Elderly people, debilitated people. And neuromuscular diseases, of course. And those who are not able to use, however you teach people to use PMDIs and pressure meter dose inhalers or dry powder inhalers, many of them will never learn. We have had patients I have had a patient who owns 2 rolling mills. Last 30 years, I could never teach him how to use an inhaler properly. He is not able to learn it. Whereas we get people, elderly ladies from villages, illiterate, you teach them and they learn it very fast and they do it very fast. and they keep on doing it very, very well. So it happens. So there are a category of people. There will be certain other people who have inadequate symptom relief by PMDIs and DPIs, where you are giving adequate amount of dosages, you have increased the dosage, you have added ICS, you have added LAMA, you have added LABA, but there is no response. In that case, nebulizers might work, so nebulizer is an option there. And those who do not comply with. Now, one of the questions, one of the reasons why what device you will prescribe depends on patient's choice also. Patient's choice has also to be taken in consideration, what the patient does best. So what we do in our practice, in my institute, is that we have vital rooms where the patient goes and the patient is seen by the people who are taught to do this. They check for their device technique and then they come back to us. They make it a point, mark in the point, plus or minus or like that. And then they write in bracket plus or minus. Some people they write minus, they cannot be told you have to write nebulize. They write nebulizers on that. So we depend on that. Then there are different other breath actuated inhalers, and we have a lot of choice these days. But still, with that, many people will not be able. Then there are many formulations may not be available. A person who can take only DPI but cannot have MDIs, can take DPI but cannot inhale it properly. It is not available. That also is availability. That also is not a problem. Availability is more of a problem. Sabas are not available in the US, but it is available. Now, people who have sudden exacerbations needs bronchocorticosteroids or a dose of drugs which have to be combined. Now there has been some studies which have shown, one of the studies done in 2017 by Sharma and his colleagues, they showed that any person who has got less than 60 liters per minute inhalation, that is optimal. Less than that, the inhalation, the dosage of drug that goes in reduces by itself, and less than 30 is totally insufficient. So what they suggest that if they have a low PIF, that is peak inspiratory flow rate, that has to be measured, and that will be a decision to change your device or change your technique, and in that nebulization could be an option. Now there are other studies by Ghosh from Calcutta. Similar things he said, that is PFR is reduced even in stable patients. He found that COPD patients in general may have a less peak inspiratory flow, and all these newer medications are coming in in DPI forms. That makes it more difficult for us. Many times I wonder how they say that our device gives a much better, very low flow rate it can go in. But when you actually practically implement that, many times it is not true. It does not work that way. Sometimes it works, sometimes it doesn't work. So 40% of the COPD patients may have reduced peak inspiratory flow rate, and that could be a reason for low compliance with the medications. And so this is low PIFR. So decreased disease control, increased risk of severe exacerbations, and increase, so it makes the patient more prone for exacerbations, and that we all know about it, nothing new in it. Now, one of the studies in one of the papers presented in American Thoracic Society in ATS in 2017, they demonstrated that people who have low PIF and those who have low this thing, who have been given DPI immediately after discharge from the patient, they had more readmissions to the hospitals. So you are discharging a patient, you are giving him a DPI with LABA, LAMA, ICS, The patient is going home and coming back to you very soon saying that patient is deteriorated. So this keeps on happen. So we have to decide in such situations what to do other than these non-DPI therapies, if they can take breath actuated MDIs or some other devices. Orals is out of question because orals you can prop them up, give them some relief for some time, but long term it is not expected them to do any harm. Now, Bumrah, Dumra, he is Harjit Dumra, he did a study in which he found that 77 patients, when he examined patients with nebulization, he found that 77% were satisfied with nebulization. 70% of the family caregivers opined that quality of life was much better in COPD patients with, and long-term relief and all these things and compliance with the treatment was much better when the patients were put on. But here it does not mean that one should put all our patients, all the severe patients on nebulizers, but it is your clinical acumen and you have to decide which patients to be put on nebulizers. You have to decide. If the patients are not doing well, peak inspiratory flow is not good, they are debilitated, nebulizers could be a good option to support them, at least temporary, till they gain their peak inspiratory flow rates, and then to do that. He made some questionnaires in which he said, he asked the patients for the caregivers. The blue line is for the patients, and the other one is for the caregivers. So what they found that the easy to use, that was one of the best portions. Feeling of well-being, that was answered only by the patient, of course, and can breathe more easily, was much better with patients and both caregivers. They were very happy with the nebulizers. So he put certain other thing, overall patient response and patients for using nebulizers for maintenance. They found that there was a feeling of dependency, there was feeling of embarrassment when other people are seeing that he is on nebulizers, but that is elderly people. I don't think that make matters much, but in overall the better control on the symptoms, fewer doctor visits, and the overall comfort and breathing, easy breathing was much better in patients who are on nebulizers. Now, the agenda of today is they want to know, the Cipla wants to know that if nebulized glycopyrronium could be used as a remedy for which patient profiles would you recommend glycopyrrolate? And have you had any clinical experience with nebulized glycopyrronium till now? That is what, it is not question from me, it is question from Cipla. I am just being a spokesperson for them for some time.
Using glycopyrronium nebulizer for
Quite a long time. Yes, we have been using them quite a lot of time, and it has been quite rewarding. Many times it has been very rewarding, but many a times these are patients who are very sick and they have to be monitored. Many of them may need LABA and ICS also as well. Now, pharmacological effects of glycopyrrolate, all of us know. It gives a prolonged bronchodilation, decreases air trapping and inflation, improves symptoms, of course, improves health, reduces exacerbation. This is what is the aim of a drug, and how it differs from tiotropium. That is what the tiotropium has been hailed as the drug in the 90s and 2000s. It was hailed as a drug which is the ultimate drug for COPD. That was what was said. Harjit Dumra, he did a study in which he found that 77 patients, when he examined patients with nebulization, he found that 77% were satisfied with nebulization. 70% of the family caregivers opined that quality of life was much better in COPD patients with, and long-term relief and all these things and compliance with the treatment was much better when the patients were put on. But here it does not mean that one should put all our patients, all the severe patients on nebulizers, but it is your clinical acumen and you have to decide which patients to be put on nebulizers. You have to decide. If the patients are not doing well, peak inspiratory flow is not good, they are debilitated, nebulizers could be a good option to support them, at least temporary, till they gain their peak inspiratory flow rates, and then to do that. He made some questionnaires in which he said, he asked the patients for the caregivers. The blue line is for the patients, and the other one is for the caregivers. So what they found that were the easy to use, that was one of the best portions. Feeling of well-being, that was answered only by the patient, of course, and can breathe more easily was much better with patients and both caregivers. They were very happy with the nebulizers. So he put certain other thing, overall patient response and patients for using nebulizers for maintenance. They found that there was a feeling of dependency, there was feeling of embarrassment when other people are seeing that he is on nebulizers. But that is elderly people, I don't think that make matters much. But in overall, the better control on the symptoms, fewer doctor visits, and the overall comfort and breathing, easy breathing was much better in patients who are on nebulizers. Now, the agenda of today is they want to know, the Cipla wants to know that if nebulized glycopyrronium could be used as a remedy for which patient profiles would you recommend glycopyrrolate? And have you had any clinical experience with nebulized glycopyrronium till now? That is what, it is not question from me, it is question from Cipla. I am just being a spokesperson for them for some time.
Using glycopyrronium nebulizer for
Quite a long time. Yes, we have been using them quite a lot of time, and it has been quite rewarding. Many times it has been very rewarding, but many a times these are patients who are very sick and they have to be monitored. Many of them may need LABA and ICS also as well. Now, pharmacological effects of glycopyrrolate, all of us know. It gives a prolonged bronchodilation, decreases air trapping and inflation, improves symptoms, of course, improves health, reduces exacerbation. This is what is the aim of a drug, and how it differs from tiotropium. That is what the tiotropium has been hailed as the drug in the 90s and 2000s. It was hailed as a drug which is the ultimate drug for COPD. That was what was said. Which have shown that the usage of tiotropium in patients has definitely reduced exacerbation and all that. Now, as we know, there are 5 muscarinic acid receptors in the body, of which the 3 are in the lungs. Now, M1 stands for causes blockade of that, causes dilatation. M2 causes constriction, and M3 causes relaxation. So overall effect, if something like ipratropium acts on all the 3, overall effect is a bronchodilation. M2 is negated by M3 and N1, and that's how we get bronchodilation, relaxation of the muscles, smooth muscles. So it has been seen, studies have shown that expert committee review for pharmacology, they have shown that there is definitely a certain advantage of glycopyronate or tiotropium, that is better receptor occupancy of M3 than M2. It has got 4 to 5 times higher selectivity for M3 than, and the bronchodilation is much more prolonged and more faster. It has got more, both of them are fat soluble, so that is why they are retained in the M3 receptors much more, but the glycopyrronium has got an extra advantage. Another advantage what I have seen practically is probably dryness is much less with glycopyrronium than with tiotropium. Now, glycopyrronium has got again a much faster dissociation from M2, and that is why cardiac side effects are also less. That has been established by pharmacology people. Dr. Varsha will agree with that, I think. Now, treatment with nebulized glycopyrrolate resulted in higher efficiency. This is there was a golden 3 and golden 4 trial which showed that in one of the golden 3 trial they have studied glycopyrronium 25 micrograms used BID and 50 micrograms BID. Definitely there is an improvement in placebo shows almost the same results, whereas glycopyrronium group it shows an improvement. The 50 microgram has got a slight edge, but more you give, more the side effects you have to consider. So in the other one it was studied, this was again studied with against placebo. Golden 3 was studied with placebo. This one was studied without placebo. That is a comparison between 25 and 25 microgram and 50 microgram, and the results have been quite satisfactory. Now, golden 3 and golden 4 trials, effect on exacerbation rates. It has been nebulized glycopyrrolate at 25 BD, decreases the percentage of exacerbation, and moderate to very severe COPD having high cardiovascular risk. So it has been established with these studies that there is an improvement, overall improvement in, and treatment emergent adverse effects were much less, and cardiac related major cardiac events were much less in case of glycopyrronium group compared to placebo. So even there was the subjects, the weakness of the studies, the number of subjects were less, but it definitely shows that there is an improvement, and incidence of major adverse cardiac events are much less in case of glycopyrronium. Now this clearly shows that glycopyrronium can be used. So what is the dosage regimen of glycopyrronium prescribed for majority of your patients? How much you use it?
Once daily.
Yeah, usually it is once daily 25 microgram or 50 microgram, well, which should be better. That is what is the question. 25.
25
BID, 25 BID or else 50 micrograms once daily. So usually I use 50 micrograms once daily or else 25 BD. That is what is I prefer. And 25 sometimes is too less once daily becomes too less for many of the patients. So now, following an acute exacerbation, what do you prescribe the patient on discharge? Suppose the patient is not able to use a device, what do you want to put the patient on on nebulizers? What would be your choice?
Nebulized triple drug therapy.
Nebulized. If otherwise the patient is okay, patient has got good PIFR and is well built and he is compliance is good, I will still go for DPI or MDI. But immediately after a discharge from this thing, I would always prefer an ICS combination and later take off the ICS as the patient improves. So nebulized ICS and LAVA can be used, but that is not recommended by GOLD guidelines. But GOLD guidelines 24 says one thing, that is a new thing, is that ICS and LAVA, if a patient with COPD is stable on ICS LAVA, there is no need to change it, change this thing. Addition of a LAMA may be helpful in patients who are not doing well. So they say that patients, if they are not getting acute exacerbation, recurrent infections or acute exacerbations, in that case, one can continue with ICS LAVA or else. Any dissent from any difference of opinion?
Majority of my patients who at the time of discharge may require very little of nebulization. They do well with my own practice.
Yeah, majority of the patients we send them with there will be some patients who are not well and who have got disabilities. They may need nebulizers, like very chronically ill patients, very debilitated patients. Like yesterday also, one of my patients who came with that, I have changed him over to of course an MDI device, and he is doing quite well now. He is taking, they called me up and told that he is doing well without the nebulizers. But for about a month he was on nebulizers. So one question, post discharge, what percentage of your patients are shifted to inhalers? Majority of them. Like Dr. Palniappan said, majority of them. Any others? So I think majority of the patients will go on that, but there remains still a subset of people, 10% of people who will need nebulizers on a long-term basis as maintenance. What percentage of your patients are co-prescribed or nebulized ICS, LAMA combination of these drugs? 20%. Less than 20%. We are talking about pure COPDs. We are talking about people who have got severe this thing and severe disease. Less than 20% will need ICS, LAVA and LAMA. Most of them will go on LAVA and LAMA and over a period of time come back to their. Now adding LAVA to ICS LAVA therapy, a meta-analysis showed that conclusion was that triple therapy provides significant clinical benefits in patients with COPD. And ICS LAVA therapy can be escalated to triple therapy whenever there is an exacerbation. Whenever there is exacerbation, patient has just recovered from exacerbation during that period till everything stabilizes. And till then you will have this. Now efficacy and safety of nebulized glycopyrronium in golden 3 and 4 studies over at 12-week phase 3 trials have shown that there is a definite improvement with nebulized glycopyrronium. Addition of LAMA definitely helps in these patients. Now what is your practice modality? Terms for follow-up visits of patients on home visualization. How do you ensure adherence and safety? That is one question. What would you do to adhere to treatment? First and sterilization and cleaning of that, which many of us forget. Even I have had issues when I have forgotten many times to instruct them how to clean it and all that. That has to be. And adherence to say, and there is no problem when the patient is not sick, but many of the patients will move away from treatment once they find that they are not.
I think like when in our center where we teach the patient how to use the inhalers, we also have to teach the patient. They buy the nebulizer and they come inside. And the girls here inside teach them how to use the nebulizer, how to clean it, and how to.
So usually what happens is practically it is not possible for us during our busy practice to attend to all patients' needs to look at the nebulizer, how it works. So there has to be somebody staff who has to be, they have to be trained and duties have to be delegated. And follow-up visits, you have to check on whether they are taking it properly or not, and that has to be seen. Now, second question is, what are the challenges and difficulties faced by your patients who are on home nebulization, and how do you tackle them? Anything you face challenges? One of the main challenges is the cost. The cost that I will talk to Cipla company, the cost actually makes it prohibitive. So many of them, they want to go back to their inhalers. Many of them have come and told that it's very expensive and find it difficult to manage. Especially the middle class and the lower middle class people find it very difficult to manage. Another thing is recurrent infections management that we have already talked about.
They also need help to someone to help them to put the
Yeah.
like inhaler where they do it.
Yeah, they have to have some assistance and something, a person living alone to do everything, cleaning the equipment, assembling the equipment, and all is difficult. And many times they make mistakes with the drugs. So I have had patients who have been taking Duolin regularly instead of taking these other drugs, which LABA/LAMA or combination that they were not taking. Glycopyrronium, for example, they were not taking that. They take whenever required, and those things. So it has to be a constant. Patient education is a must. Any other suggestions you can come up with?
General practitioners are starting them on solute-down nebulizer. So people think that it's cheaper, doctor is giving costly drug for us. They think all the nebulizer drugs are same. So they think cheaper drugs are available in market for the insurance.
That is, awareness has to be created. Creating awareness about. See, one of the major problems with nebulizers is we have no control on the nebulizer dosage that goes inside the body with nebulizers. We have no control because you are putting in some solution. For example, salbutamol. You put salbutamol, one DPI will give 200 micrograms, means this will give 5 ml you are putting, that is 5000 micrograms. This is something is going from the sides, from the ports, some is going. With the mouthpiece, the inhalation is much better. If the patient is keeping the mouth open, through the nose, the hairs in the nose and nasal cavity actually reduces it by 50% absorption. Opening the mouth, the absorption is about 65% absorption. Rest goes away. So we have no quantification of the disease. So every time, this thing is that if a patient can be on devices, it is better. So this nebulization is patients who are very severe, like we had a list of conditions in which the patient is not able to inhale, PFR is very low, debilitated conditions. Those are the candidates who have to be. And the dosage has to be titrated. Even if it is glycopyrronium, it can be started with a higher dosage. And if the patient is doing well over a period of time, it can be titrated to an optimal dose. It can be brought down to 25 micrograms, even once daily as well. I would like some inputs from you. You would like to take that.
Thank you, sir. So a couple of questions, if like we all could interact and we all from your rich practice, if you could let us know. Like sir has also asked us about in which patient profiles do you recommend nebulized glycopyrronium? Like if we consider if we consider gold, so gold is talking about group A patient start with single bronchodilator, group B patient sabasama, group C if the eosinophil count is higher then sabasama ICL. So likewise if we get some insights like on the patient groups that you prefer giving nebulized any of the nebulized drugs, especially the glycopyrronium. How do you start? Uh, Dr. Brighton, if you could let us know, how is your experience?
பேஷண்ட்டு டிபிஎல் எம்டியில் இருக்கும்போது பேஷண்ட் ஏதாவது அட்மிஷன் ஆகும்போது எக்ஸாசர்பேஷன் இருக்கும்போது மோஸ்ட்லி நான் வந்து நெபுலைஸ்டு கிளைகோபைரனியம் ஸ்டார்ட் பண்ணுவேன். எக்ஸாசர்பேஷன்.
Dr. Anand, if you could.
So usually in gold stage 3 and stage 4 where the FEV1 is very low, and when the patient gets discharged after an acute exacerbation or immediately after an ICU event, so in these group of patients we generally give home nebulizations, that is triple drug combination along, we usually prefer glycopyrronium in those group of patients.
Doctor, if you are giving the triple combination nebulization, then how long a patient prefers and how long you prefer giving?
So usually when most of these patients with acute exacerbations, we usually advise them to keep on home nebulization for 2 to 4 weeks. Then we will assess them based on the clinical condition. We will either step them to their previous inhalers, which they were very comfortable earlier. That is either LABA-LAMA combination or either ICS-LABA combination.
Thank you, Doctor. Dr. Anand, what is your opinion on this? How do you start giving glycopyrronium at which stage?
Mostly for inpatient. Mostly for inpatient to use nebulized glycopyrronium. And in patients who are on home-based oxygen therapy, who are not able to take the other devices.
And the duration for which you are giving nebulized and how is their response? Right now, Dr. Unithan also has mentioned that affordability is an issue. Of course, inpatient they have to be taking, but otherwise, when you are switching them to home maintenance nebulization, how it is received by the patients, whether it is received well or not, how is it?
Yes, ma'am. Actually, only the economical thing is the drawback. So, if they are not able to, we have to switch to other meter-dose inhalers with spacer. If they are able to, I think patients are comfortable with nebulizer than the other two devices.
What is like the percentage? Like if suppose you have just a random example, just for understanding. Like if you have 10 patients and you have discharged, I mean they have been discharged and on nebulizer, then for how is their response and for how long they would like to be taking it? Like how is or it is quite subjective maybe.
Few patients take if they are not able to take the meter-dose inhalers, so they are doing it for regularly. But mostly within 2 weeks we'll switch on to other meter-dose inhalers.
In my practice, what happens is the patients who are not able to take any devices, we put them on nebulizers, home nebulizers, and many of them are chronically on home nebulizers. Some of them I have never tried to bring out them because they are very comfortable and stabilized with that. So these are very few people. Otherwise, most of them we try to reduce because of the reasons are two. One is the side effect of the drugs, like too much of drug going in. One. Another thing is cost. These are the two options that we consider.
The third issue is the quality of nebulizer also.
Yeah.
We get lot of nebulizer which produce, so it looks as though it works wonderfully well, but not effective. So we get lot of substandard nebulizers in the market.
Like
Yeah,
people are going for the
Yeah, they go
machines
for a
which
cheaper.
they can
They can afford.
which is practical.
Yeah, they go for a cheaper nebulizer and then ultimately it doesn't work. So that's one other issue with nebulization.
Out of context, can I ask you, do you have any facility to check these nebulizers whether the particle size is respirable particles or not? Any methodology?
Any methodology at this moment we are
No, I mean commercially available methodology. There is methods.
yeah.
That is different thing. I'm asking commercially available any.
So at this moment, since they are coming from different companies, like maybe we are not in position to talk about because they have products
No,
of
it may
different
not be,
companies.
it can be some testing authority which is neutral, which they can test any nebulizer given to them and check for.
Yeah, that's what I'm asking
Yeah,
you.
that's what sir is.
There has to
Yeah,
be
in
something,
that
somebody, some regulatory
Yeah.
this thing to
Standardization.
check it. So if the patient comes to us and says that I have bought this nebulizer, I can ask them to go and check with them whether it is good nebulizer or not.
Like
Hello,
what,
Vano,
like
actually.
you are talking about like CDSCO, like that we have for drugs and for how the device, there is act which has come up, revised in 2017, but we are, like at this moment I do not have information like how nebulizers are compared. So I'll surely get back with this information, like how the capacity of each
This is
one
what suddenly came to me.
No, but this is very
When
good
he
piece
said
of
that-
information even to understand.
Like you have scintillography
Yeah.
to know if the drug deposition is good, but scintillography is not practically possible to do in that patient. So similarly, devices,
There's some regularity.
yeah, there has to be, there is a proof that this is actually reaching.
Yeah.
Even spirometry also we calibrate regularly. That is something to calibrate some nebulizer.
Sure, I'll get back with this piece. Dr. Rajesh and Dr. Premanasan, if you could let us know, like, how is the duration of therapy when you're putting, what is the duration of therapy? Again, I'm coming back to the same question just to understand, like, how nebulization, particularly glycopyrronium, is being received. That's what the aim is. So I'm coming back to you with the same question.
Yeah,
Like, what is the
just
duration?
We usually provide LAMA, ICS combination of nebulization. We usually commercially available ones of formaldehyde, budesonide, depending upon the. Even we have hard formaldehyde separately. If you want more potent drugs, you can go for fluticasone also. It's available in Cipla, I guess. And with the added LAMA, the only LAMA available is glycopyrronium. So we initially start with BD and try to taper off. Usually we call for a review, and most of those patients may be having a concomitant type of respiratory failure also. They may be with added NAV or CPAP or OSA or whatever. So in that case, usually call for review after 1 week or 2 weeks. At the time we will be tapering the steroids also. So we can usually tend to continue for another 1 or 2 weeks, depending upon the patient's acceptance, severity and affordability. Normally more than the nebulizer, actually nowadays, nebulizers have come into the price control for the past 3 months. It's available for 1,800. Most of the brands, they have reduced the price. Few costing around 4,000, 5,000. So more than it's easy to convince them to buy a nebulizer unit as such, but as discussed, as Panikut has said, quality of the machine also matters, which we don't usually look into it. And most of the people, the moment we write nebulizer is, they go for Flipkart, Amazon. don't buy it from Velamal pharmacy.
So then on Flipkart, Amazon, food companies are also available, but then they will check whether 700, 800,
It depends,
900,
you know, who
to buy.
provides,
Even we do that.
who provides more discount, they will go
They
for
will
it.
prefer buying.
So we cannot, however we try to convince or whatever we do, final thing is cost. And Google is already available for that.
Yeah, that's.
Whatever we try to enforce, it's very difficult to convince. They may be silent till they get well, but as soon as they get well, they'll be like, no, it's very costly.
But then,
And that's the time when the lung function improves also probably after 2 weeks. So we switch over usually to MDA or GPA depending upon. Or sometimes even some patients are like, no, we don't want just. Or they themselves tell. Like for example, if I given a LAVA ICS combination BD and LAMA nebulization BD, what they do is they make LAVA ICS once a day. They may take in the morning. They try to taper it up and they come and report it, it's good. Okay, then continue. Because all the drugs are believed to work for at least 12 to 18 hours. It's not just 12 hours, right? With formoterol, glycopyrronium, they may work up to 18 hours also. In that way, it is OD formoterol and OD LAMA also works 2 weeks after, 1 or 2 weeks after exacerbation.
so like that, doctor, if these patients they are to be put, ideally they are to be taking drug every day, like after nebulization they are taking LAMA suppose every day. But what is the percentage of patients who are really in practice, who are every day for years they are taking drugs? Like, are they doing, or like we have a tendency that if you feel little better, you stop. Are they doing that?
No, some are like, they're happy with it, they don't want to go back to nebulization. I mean,
No,
they don't want to go
even
back to.
inhalers, I'm saying.
Severe patients.
Severe patients, they
Severe patients
They know
don't.
if they stop, they're going to die. It's only
Com-
the mild and moderate who may.
One thing I have found is,
Reducing their only.
Like asthma also.
Yeah.
one thing I have found is the compliance to treatment is directly proportional to the duration of illness.
Severity of illness.
It's definitely proper. Patient has got only had problem for 1 month, after some time they will stop. Patient had it for 10 years, they will continue.
More severe, they know if they discontinue, they don't do it for.
And usually during weather, I mean, with exacerbations they will take. And summer they won't even come for review also.
How often do you check it with pulmonary function testing?
Every 6 months.
Every
If
6
they come for
months.
review.
We do PICO in every visit.
Yeah.
Yeah, PFR.
But PFR,
To some extent.
how much it is reliable or
COPD.
COPD?
Yeah. But at least some information you get.
It's better
Better than nothing.
Nebulization treated how many days once it has to take over months?
Can be changed. Whenever it, I think it has to.
changes.
Ideally, these kits which we are using are disposable kits. They are supposed to be disposable, use it and throw. But we don't do that, we continue it for some time till they work, but it's, as long as that, what is called,
Changes.
baffle is there, that is intact and is aerosolizing, you can use it. Most of the time in the kit, the problem happens with the tubing. Tubing actually kinks at one side and nothing comes. These people keep on using it. It goes on for 10 minutes, 15 minutes and people keep on and take it out. That is, you have to see. So usually it lasts for 3 months, it lasts definitely. 3 to 6 months it lasts.
And during cleaning also, majority of the people have lost their baffle. Without baffle, they will be keeping
Yeah.
nebulizing, they will not be able to from it. So ultimately, they come out with excess circulation. I was in 2 patients.
So that is a special instruction. That is an instruction you have to regularly give it to them.
Sir, do you advise gargle after nebulizer use?
Huh?
Nebulizer use. Gargle after nebulizer use.
Definitely, whenever there is steroid, yes. ICS is there, corticosteroid is there, you have to nebulize. Others you need not. There is nothing definite about it.
Some people they feel like dryness. Nebulized glycopyridine.
Yeah.
Glycopyridine, I don't think you require goggle.
Even
But with
with
steroids,
steroids, some people complain they have dryness.
Yeah, dryness is a part of LAMA. LAMA, anticholinergic agents will have dryness. And dryness is much less with glycopyrronium compared to tiotropium. But still, there are people, one of the major side effects people complain is dryness of the mouth.
What do you advise, sir? I advise immediately you gargle after taking it.
I say you keep sipping water or drink, convince them that this is nothing, a minor problem, drink water. If impossible the patient becomes, then take it off, nothing else we can do.
a few other patients will come to the difficulty in talking. They are not able to talk because of the dryness.
Some people they used to say that I don't know this change because of the dryness.
Yeah, there are people who complain about it. Dysphonia is one of the major problems with inhaled medications, especially involving corticosteroids.
It's better to tell them in advance that you may develop this thing, so that they will be more aware that
Especially many people come and tell that they were singing, now they find it difficult to sing. Difficult to sing.
One thing about nebulizers, I felt there was a period when a few companies came up with this handheld nebulizers, the mesh nebulizers, which could be operated with batteries or even like you can charge them.
Mesh.
Mesh
Those are
nebulizers.
very comfortable, but due to some reason, they all stopped it.
Cost was high.
Cost was
the
high.
battery life was
Even I think the handheld nebulizer which I was using, I think it was costing around 5,000 rupees. But if you have a patient on nebulizer, the monthly charge itself will be higher than that. The drug charge I'm saying. So the 5,000, 6,000 rupees cost of a nebulizer is not a big deal comparing to what they are actually paying to the medicine. So now if you put someone on triple therapy nebulizer, the cost will be, I think it will be about 10,000 a month. I don't think it will be below that.
But they don't do this.
But in general,
I wanted to just
mesh nebulizers, the lifespan is very
that's what I'm telling. Maybe these companies, they can put their R&D into that. They can develop some sort of, better versions of hand nebulizers. Because the major drawback with nebulizer is the volume, the size, and they need a power backup, everything. So, to move on to the next one, I think once we bring in more handheld nebulizers, this using nebulized drugs will be much more easier and comfortable.
Usually what I do is, if a person is affordable, I ask them to buy a stable electrically operated nebulizer for home use and keep this as a reserve for when traveling or going somewhere.
That's because we don't have good quality handheld nebulizers. So if you have something good, we are not going to go into these nebulizers at all. That can be prescribed for everyone.
The biggest problem with the handheld nebulizers is the cost. We had launched one of the nebulizers which is NebuFlow. Many of you must have got that NebuFlow nebulizer we had distributed last year. The costing part is the biggest problem for us.
How much was it?
We are working with our R&D team as well. So as a marketeer, what the biggest problem we had was the costing. The biggest advantage
was
was
the cost?
5,000 rupees onwards. That's the biggest problem we had with the mesh nebulizers.
What I'm
NebuFlow
telling
was
is, see, you have now your Cipla, Porocard Rispil. If I prescribe Porocard Rispil, say 1 milligram twice a day, what is the cost per month? It will be more than that. So actually, even if you say it's 6,000 rupees, the handheld nebulizer is, it is not. It will be less than what he actually pays for 1 month of medicine. So it's not a very big deal.
yeah, even I mean we also buy the same point. The entire last year.
What I felt with handheld nebulizer, it was not the cost. All my patients who I prescribed them, they were ready to buy it. The only thing is it couldn't sustain. The quality was very bad. It started giving problem maximum in 2 or 3 months. And the mesh was replacement we could not get. All those things. It was not the cost that was actually hindering, it was actually the quality of the equipment.
which, if we could get information, like which were these like, names of these companies?
I think Glenmark.
There is one or two company. One is from Glenmark, one is from Lupin. But none of the company got success in this particular device. So that is the reason last year we had given it free of cost to all of the doctors. Almost 14,000 nebulizers, these mesh nebulizers, we had given free of cost to the doctors. Almost we had a success rate of 70-80%, but few other places doctors were complaining about it. But the biggest the problem was again the costing one. Doctors were giving it to the patients, but when they had to buy it again, that was the part. But the biggest advantage was, as you said, I mean, it is portable one. Patient can carry it anywhere. It was handy. Just patient had to charge it 1 hour, then he can use it for 3-4 days easily. But we are working on it, sir. Definitely in coming time we should get some news on that as well.
Any possibilities of triple drug therapy as a single rescue?
Yeah. We have two different divisions, NEP1 and NEP2. So NEP2 is launching it in RESPL format as well. So the division which looks after Coracor, so they are launching it in triple drug formulation as well.
That's the most pressing need, and that's the question that we get. How is it?
Coracor G is already there in the market, but now in RESPL form, we are also launching that as well.
One of the biggest drawbacks of nebulizers is actually the time. My daughter, I am not able to make her use nebulizer. Because you use an inhaler, hardly takes you 1 or 2 minutes to use. But sitting with the nebulizer takes around 10 to 15 minutes. So that's a very big.
But usually a person who is using a nebulizer, he is a person who is very sick and is at home. Most of them, they are retired people, elderly.
Require a nebulizer only during exacerbation, right?
That's an exacerbation time. I will like two நிமிஷம் வச்சு தூக்கி போட்டுருவாங்க. அதுக்குள்ள வைக்க மாட்டாங்க. ஆனா இன்னேலர் அடிச்சோம்னா she is comfortable. அது
some amount of
why one thing I don't understand is why with nebulizers mouthpieces are not mouth held. This thing is not very popular. Why they are all coming with masks?
So it comes to both. Is this both are
all the kids are not there.
But majority was used.
If you buy a nebulizer, they don't. Many of them do not have a mouthpiece.
No, sir, it contains.
All the nebulizers are.
I have seen almost all. There is but we don't take her. We ask them to go.
இப்போ வர kids எல்லாமே மூணு இருக்கு சார்.
மூணு இருக்கு. ஒரு adult, ஒரு kid.
Adult, one kid and plus
mouthpiece is, sir.
I thought mouthpieces are with very few companies.
Yes, sir, it comes with all the companies.
Yeah, all these are influenced by media. சினிமால எதை பார்க்குறாங்களோ அதை தான் people use. Inhalers வந்து ஸ்பேஸரோட எந்த சினிமாலையும் காட்ட மாட்டாங்க. So ஸ்பேஸர் இல்லாம தான் people they go. நம்ம nebulizerனால எல்லாமே மாஸ்க்ல தான் மூவில பார்க்கறாங்க.
Same with DP also.
All these are what the media projects they do.
But even we don't use it in our own hospitals.
Hospitals are sick than sir. அவன வாயில வச்சு உரிய சொல்றாங்க.
Another advantage is patient has to hold it. They can just tap it off.
Yeah.
That is one advantage. Right. Even they feel that the amount of drug getting into the lungs is more with the mask.
Yeah, so it is psychological more that you feel more comfortable using masks than.
Any of you are asthmatic? I am an asthmatic. I have used nebulizers. I have taken with mouthpiece. I have taken with this. Those days I have been
comfortable with
I have found no difference actually.
Maybe
I have not found any difference.
coordination.
And I am an asthmatic during my college days when there was no inhaled medications at all. Aminophagin injections.
நிறைய பேஷண்ட் வந்து என்டி டிபி ஓட வந்து நெபுலைசேஷன் வந்து கொஞ்சம் சுப்பீரியர் அவங்களா நினச்சிக்கணும் அவங்களா
It's not just psychological. When you think about, we subtract all the confounding factors.
Yes, no,
the studies mention that it is equally as efficacious, all those things. But practically you speak, I think for those patients who are out of exacerbation or during exacerbation, definitely all these things will be.
See, basically any drug is going to work only if it goes into the lung. So when the patient should be able to take the drug into the lung.
I think delivery will be more with
See, what I personally feel is rather than the drugs, it is whether the patient is able to take that drug into the lung that matters.
Does, if I may ask, like, does education matters, like the level of education matters when they are using the nebulization, or it is the same, like it may happen that the patient is not much educated, but you are instructing him and he is following it.
See,
Or he
nebulizations
is
are
very
easier.
educated and not being able to use it. How is it?
No, I don't think education makes a difference with nebulizers. Only thing is instructions given to the patient. Like many people know, they breathe normally, they keep their mouth closed. The deposition is much less. If you open your mouth and breathe, or in between you take a deep breath, much more quantity goes in. So it varies how they are instructed. Education, level of education does not matter. That is what is the problem. Advantage with nebulizers is that there is no problem with delivery of the drugs. Delivery of the drug is quite easy. Whereas devices, you have to have a proper technique. You have to hold. Breath holding is one of the most difficult things these people feel. Most of them, they exhale out, take it inside and exhale out, or they are not taught properly, because partly not because of because the physician is ignorant or his staff is ignorant or they don't have time, and a lot of such issues.
Absolutely, there is a study like which is saying that the educators, like even the staff, is not trained in using trained in training how to use the nebulizers as well as inhalers. So almost 30-40% of them know actually how it is to be done, and then that much information is percolating. So it is really a challenge.
We face this problem many times because we have 2 vital rooms and we have 3 or 4 people posted in each. So what happens is sometimes these people, one of these ladies, they go for a bronchoscopy. That lady who is in charge, we rotate the staff. So when we rotate them, we find that patient comes and tells, that person told me like this, today this person is telling me in a different way. That is standardization you have to do. You have to keep on training your trainer. Train the trainer is the most important thing. You have to keep on training the trainers. They have to be kept at. So we take in between. We have made it a mandatory. Every 3 months we call them. We take. I took 1 month back classes for all these people.
Even we have some programs like
we had it last.
Even that program is getting success.
Yeah, I think your people have come once and told them.
School format as well. So the division which looks after Corapod, so they are launching it in triple drug formulation as well.
That's the most pressing need, and that's the question that we get all the time.
Corapod G is already there in the market, but now in Respil form, we are also launching that as well.
One of the biggest drawbacks of nebulizers is actually the time. My daughter, I am not able to make her use nebulizer. Because you use an inhaler, hardly takes you 1 or 2 minutes to use. But sitting with the nebulizer takes around 10 to 15 minutes. So that's a very big.
But usually a person who is using a nebulizer is a person who is very sick and is in a home. Most of them, they are retired people, elderly.
Require a nebulizer only during exacerbation, right?
That's an exacerbation time. I will வைக்க வைக்கிறதே நான் முடியல ஒரு 2 நிமிஷம் வச்சிட்டு தூக்கி போட்டுருவாங்க. அதுக்குள்ள வைக்க மாட்டாங்க. ஆனா இன்னேலர் அடிச்சோம்னா she is comfortable. எனக்கு அது கூட
Why? One thing I don't understand is why with nebulizers mouthpieces are not mouth held. This thing is not very popular. Why they are all coming with masks?
So it comes to both. Is this both are
all the things are not there.
But majority of us use
If you buy a nebulizer, no, they don't. Many of them do not have a mouthpiece.
No sir, it contains.
All the nebulizers are.
I have seen almost all. There is but we don't take care of this. We ask them to go.
இப்போ வர கிட்ஸ் எல்லாமே 3 இருக்கு சார்.
3 இருக்கு. 1 adult, 1 kit.
One adult, 1 kit and plus
mouthpiece is, sir.
I thought mouthpieces are with very few companies.
Yes, it comes with all the companies.
Yeah, all these are influenced by media. Cinema la edha paakranga adan people use. Inhalers வந்து ஸ்பேஸரோட எந்த சினிமாலையும் காட்ட மாட்டாங்க. ஸோ ஸ்பேஸர் இல்லாமல் தான் people they go. நம்ம நெபுலைசர்னால எல்லாமே மாஸ்க்ல தான் மூவில பார்க்கலாம்.
Same with DP also. They never shown in.
All these are what the media projects they do.
But even we don't use it in our own hospitals.
Hospitals are sick ஆன சார் அவன வாயில வச்சு உரிய சொல்றாங்க.
Another advantage is patient has to hold it. They can just tap it off.
Yeah.
That is one advantage. They have tried. Even they feel that the amount of drug getting into the lungs more with the mask.
Yeah, so it is psychological more that you feel more comfortable using mask than.
Any of you are asthmatic? I am an asthmatic. I have used nebulizers. I have taken with mouthpiece. I have taken with this. Those days I have been
comfortable with Cipla.
I have found no difference actually.
Maybe
I have not found any difference.
coordination.
And I am an asthmatic during my college days when there was no inhaled medications at all. Aminophagium. Injections.
நிறைய பேஷண்ட் வந்து என்டி டிபி ஓட வந்து நெபுலைசேஷன் வந்து கொஞ்சம் சுப்பீரியர் அவங்களா நினச்சிக்கணும் அவங்களா
It's not just psychological. When you think about, we subtract all the confounding factors. No, both the studies mention that it is equally as efficacious as all those things. But practically you speak, I think for those patients who are out of exacerbation or during exacerbation, definitely is all these things will be.
See, basically any drug is going to work only if it goes into the lung. So when the patient should be able to take the drug into the lung.
I think delivery will be more with the.
What I personally feel is rather than the drugs, it is whether the patient is able to take that drug into the lung that matters.
Does, if I may ask, like, does education matters, like the level of education matters when they are using the nebulization, or it is the same, like it may happen that the patient is not much educated, but you are instructing him and he is following it. Or he is very educated and not being able to use it. How is it?
No, I don't think education makes a difference with nebulizers. Only thing is instructions given to the patient. Like many people know, they breathe normally, they keep their mouth closed. The deposition is much less. If you open your mouth and breathe, or in between you take a deep breath, much more quantity goes in. So it varies how they are instructed. Education, level of education does not matter. That is what is the problem. Advantage with nebulizers is that there is no problem with delivery of the drugs. Delivery of the drug is quite easy. Whereas devices, you have to have a proper technique. You have to hold. Breath holding is one of the most difficult things these people feel. Most of them, they exhale out, take it inside and exhale out, or they are not taught properly, because partly not because of because the physician is ignorant or his staff is ignorant or they don't have time, and a lot of such issues.
Absolutely, there is a study like which is saying that the educators, like even the staff, is not trained in using trained in training how to use the nebulizers as well as inhalers. So almost 30-40% of them know actually how it is to be done, and then that much information is percolating. So it is really a challenge.
We face this problem many times because we have 2 vital rooms and we have 3 or 4 people posted in each. So what happens is sometimes these people, one of these ladies, they go for a bronchoscopy. That lady who is in charge, we rotate the staff. So when we rotate them, we find that patient comes and tells, that person told me like this, today this person is telling me in a different way. That is standardization you have to do. You have to keep on training your trainer. Train the trainer is the most important thing. You have to keep on training the trainers. They have to be kept at So we take, in between, we have made it a mandatory. Every 3 months we call them, we take, I took 1 month back classes for all these people.
Even we have some programs like program for people.
Yeah, we had it last.
Even that program is getting success.
Yeah, I think your people have come once and told them and. Yeah. Yes.
I thank Dr. Onithan for his Dr. Onithan for his valuable insights and I thank all the eminent panelists for their valuable insights. So with this, we conclude the meet and we can go ahead for the dinner. Thank you so much.
Personally, I would thank on our side.
Thank you. Thank you. It's nice to meet people.
Thank you so much.
And we also got to know the practical things. Like we talk about nebulization, why people are not taking, but the real challenges like when we discuss, we get to know that cost is the factor. Nebulization, as you mentioned, is the device is the factor. So, yeah. Thank you.
Thank you.
In our country, the major factor is cost.
For everything.
Ours is a cost conscious. And now nobody, no insurance now.
Pension and no insurance. Because if you have pension, you at least think of.
My daughter is in Cipla. So she has been stopped and she has not occasionally some lease. So I told her, you either go and meet a pulmonologist. She went and met a pulmonologist. She was a doctor, one spirometry, one FE1.
Sir, other thing is Indians are lucky because in Canada, just to reach to a pulmonologist, it takes 7 months.
Yeah.
Such a